Great. Thank you. Thanks, Chris. And thanks for the 20 people that stuck around for the, the meeting today. What I want to talk about today is optimal management of the displaced femoral neck fracture in the elderly. And I just want to go through some of the literature, particularly randomized controlled trials, as well as national registries, what the registry data shows. Disclosures, I do have a royalty from Inamed for a product invention. Scope of the problem, there are 300,000 hip fractures per year in the U.S. A little over 1/3 of these are displaced femoral neck fractures. These fractures carry a high mortality, not like they carried in the past, but there's still 25% one-year mortality, which is double the age-matched control. Tremendous loss of independence. 64% of patients will be admitted to a skilled nursing facility at least short-term in the year following the break, and double the rate of long-term admission to a nursing home at 5 years. Historically, the displaced femoral neck fracture was dubbed the unsolved fracture. This was due to poor results of both operative and non-operative management. Back then, we had poor reduction and fixation techniques, certainly by modern standards. There was no reliable mode of replacement, and this resulted in high rates of avascular necrosis and non-union. The timeline in 1950s, we saw the introduction of the Hemiarthroplasty, first-generation Hemiarthroplasty, the Austin Moore. In the 60s and 70s, we saw improved fixation techniques, and we understood the principles a little bit better of operative fixation. On the arthroplasty side, cement was introduced. We had introduction of the bipolar prosthesis, and eventually the advent of the total hip arthroplasty. 80s and 90s brought portable fluoroscopy, which improved our reduction techniques as well as pin placement. Cannulated screws improved the accuracy of pin placement and reduced the risk of cortical perforations. On the arthroplasty side, we saw the introduction of so-called third-generation cement techniques, which improved the long-term fixation of the implants, porous-coated implants, which theoretically at least would give us long-term, perhaps permanent fixation on the femoral side, and modular designs to tailor the length and offset to minimize dislocation and maximize function. So where are we today? Currently what's thought to be the best treatment option for these patients? Is it fixation? Is it unipolar hemiarthroplasty, bipolar hemiarthroplasty, total hips? Should the stem be cemented or uncemented? And what approach is best? And those are the answers we're going to try to answer. Those are the questions we're going to try to answer today. Or does it depend on the age and function of the patient? One caveat is that these patients don't live forever. There's an 85% mortality of displaced femoral neck fractures at 13 years. So we probably don't need to plan for long-term fixation in these patients. But if we get 15 years of use of whatever implant we choose to use, that's probably good enough. So numerous trials suggest arthroplasty versus ORIF. Is it better to fix these things or is it better to replace these things? Numerous trials have suggested decreased blood loss and OR time for fixation, decreased need for transfusion with fixation, equivalent survival rates, both short-term and long-term, and at least short-term decreased cost of reduction in fixation. However, these same trials also show a high risk of reoperation for fixation procedures, 25 to 50% versus less than 10% for arthroplasty. In general, improved pain scores with arthroplasty, markedly decreased cost of arthroplasty at 2 years, secondary to reoperation of failed ORIF, and this is due to the cost of the additional cost of the implant and additional surgeries. Increased incidence of limb shortening, of significant limb shortening with fixation, and inferior functional outcomes. Harris hip scores are inferior, gait velocity is inferior with ORIF. If you look at Harris hip scores, almost universally better with arthroplasty. They're better short-term, they're better at 6 months, they're better at 12 months. This is especially true for total hips, less true for arthroplasty. At 2 years, there seems to approach some equivalence, but this is only in studies that excluded revised patients. If you include revised patients, there's persistent improvement of the Harris hip scores across the board out to 17 years with arthroplasty. So my conclusion would be that arthroplasty is preferable to reduction in fixation in the older patient with a displaced femoral neck fracture. Now, if you're going to fix them, you must be willing to accept the 30% reoperation rate or failure rate and perhaps inferior long-term results. Now, how old is older? We will get to that. So should the femoral stem be fixed? should the femoral stem be cemented or uncemented? The theoretical advantage of uncemented fixation: decreased operative time, decreased blood loss, decreased risk, we thought, of intraop or perioperative death. You weren't getting that bolus of cement monomer and fat emboli into the system. Would there be improved, theoretically at least, improved long-term fixation secondary to decreased long-term loosening on the femoral side? Except for OR time, these theoretical advantages have not panned out. Perioperative and long-term mortality are essentially identical in most studies. Equivalent pain and function at 10 years, and most people do not live long enough to perceive the benefits of cemented fixation. In addition, there's clearly an increased fracture risk with uncemented fixation and an increased revision risk. So the revision rate for uncemented fixation is anywhere from 6 to 12% compared to less than 2% for cemented fixation. This is true of all comers. This is true whether you're doing a hemiarthroplasty or total hip arthroplasty. It's true for collared and non-collared stems, fit and fill stems, tapered, porous coated stems, HA stems, grit blasted stems. In virtually every study, cemented fixation has a lower, appreciably lower periprosthetic fracture rate. Perhaps more worrisome is there's a persistent increased incidence of periprosthetic fractures at up to 5 years with uncemented implants, which suggests that perhaps cement adds some strength to the proximal femoral construct. So it's not just intraoperative and short-term postoperative fractures to worry about, but really more longer-term fractures. When the National Health Service looked at this, they found their conclusions were a little different. They did see an increased incidence of fractures with uncemented stems, but they said it was only a little bit different than uncemented stems for elective hip arthroplasty, and they thought there might be an advantage, a late advantage for the younger patient to have uncemented fixation. So although they saw the increased risk, they did not think it was alarming. The Swedish registry, if you look at cemented stems, they clearly outperform cemented stems in the first 8 years, but in the second 8 years, uncemented stem survival surpassed that of cemented stem survival, and they concluded that uncemented stems might be preferable in younger patients. So the take-home message here, I think, is cemented fixation appears to be superior for all patients over the age of 70. Having said that, there's still a high use of uncemented fixation in the U.S. There's not good numbers on this, but it appears that over 50% of hemiarthroplasties and total hip arthroplasties for femoral neck fractures in the U.S. are done with uncemented implants. An informal survey at the Hip Society this year, 75% of respondents, now you have to take this with a grain of salt, these are all hip arthroplasty specialists for the most part, that 75% of respondents felt that the uncemented porous or HA-coated stem was their primary treatment of choice for these fractures. So what does that tell us? Well, either hip replacement surgeons can't read, they think they know something the data doesn't know, or, and this is what I would submit, they are creatures of habit, like most of us. Choice of approach. It's clear that the posterior approach is inferior to the lateral approach for these fractures, particularly with total hip arthroplasty. Across all series, higher risk of dislocation with posterior versus lateral approach. People have looked, there's been a trial, several trials looking at a posterior approach with dual mobility, and although a dual mobility socket for the non-arthroplasty people is almost like an internal bipolar in a total hip socket, still a higher risk of dislocation with the lateral approach, and it's expensive. We don't have good comparative data on other approaches. We really don't know how the anterior approach stacks up to other approaches. So the conclusion, use lateral approach when feasible. Caveat is there have been a number of studies that show that if a surgeon takes on an approach he's not comfortable with, especially with total hip replacement, that the risk of dislocation goes way up. And the risk of component malposition goes way up. So be comfortable with the lateral approach. How about unipolar versus bipolar? There are certain theoretical advantages of a bipolar, or so we thought. Decreased dislocation risk, perhaps, improved range of motion, decreased acetabular erosion, decreased pain, and perhaps better long-term results in survival. Disadvantages, though, is a high cost of the implant. If you looked at early studies, there was some data that suggested that the bipolar was superior to the unipolar. That's been called into question. It's really not a fair comparison. They were comparing Austin Moore uncemented stems with a cemented stem with a modular neck, not a fixed head, and the improved results of the cemented fixation were due to the fixation rather than acetabular wear. Most modern designed randomized controlled, most randomized controlled trials with modern implants show a decreased dislocation, no decrease in dislocation rate with a bipolar implant, no improvement in motion, no decrease in pain. Acetabular erosion is a little hit or miss. Some studies have shown decreased acetabular erosion once you hit the 5-year mark, others no change at all, even long term. The Australian registry, however, reported decreased risk of revision with bipolar at over 5 years in patients under the age of 70, and they recommended considering bipolar in younger patients. Conclusions: no clear advantage of bipolar over unipolar, except in patients perhaps under 70. For most, we cannot justify the added cost. These younger patients that might be better served with bipolar hemiarthroplasty, I would submit, would be better served actually with total hip replacement. And I think bipolar should have a reasonably limited role in the management of these fractures, assuming there's not price neutrality. How about a monoblock Austin Moore type stem? And to this, I would include any uncemented, non-porous, coated, non-grist-blasted stem. These stems are simply inferior to cemented modular implants and inferior to uncemented implants in multiple registries. I believe they should be relegated to the ash bin of history. They're still, interestingly, as recently as 2011, even though the NHS recommended against their persistent usage, there was still a 90% usage rate in the UK. I would say don't use them if you can avoid them. How about total hip versus partial hip replacement? Advantages of total hip: better function, better pain scores. Theoretical advantages, I should say: better function, better pain scores, decreased acetabular erosion, at least theoretically, and a better long-term survival. Disadvantages of total hip: increased risk of dislocation, increased overtime and blood loss, and perhaps requires more special expertise. If you look at the big trials, dislocation risk is clearly a little worse with total hip arthroplasty, and that risk is early on as well as later on. If you look at functional results, though, consistently improved functional results with total hip arthroplasty versus hemiarthroplasty, looking at Harris hip scores, quality of life indices, gait velocity. If you look at pain as a sole indicator, 94% of hips in one study were pain-free at 94% of total hips were pain-free versus only 55% of the hemiarthroplasties. If you look at the risk of reoperation, most studies suggest increase of risk of reoperation with hemiarthroplasty, and that risk can be anywhere from 3 to 4-fold what total hip is at 13 years. If you look at blood loss, overtime, transfusion risk, all a little greater with total hip arthroplasty. There is no difference in mortality, and this is something I would say across the board. There just does not appear to be a big significant difference in mortality rates, regardless of whether the fracture is fixed, replaced, or whether total hip replacement is done. So the conclusions I would submit is that total hip arthroplasty results in superior functional results, superior long-term results, and this is especially true in younger individuals. It does, however, come at the cost of an increased risk of dislocations. Under the age of 70, I believe that total hip arthroplasty should be the treatment of choice. At 70 to 80, it becomes more dealer's choice depending on your expertise and patient's comorbidities, perhaps. And at over 80 or significant comorbidities, I believe hemiarthroplasty is a better choice for most individuals. How about cognitive impairment? One good trial to look at this: patients with severe cognitive impairment. Historically, it was thought that maybe we're better off fixing these people rather than replacing them because of a risk of dislocation, and that these patients perhaps can't be trusted to monitor their strict hip precautions. If you looked at reoperation rate, it's quite high if you fix them versus replacing them. Quality of life scores are better with hemiarthroplasty as well. This has to be tempered with a 30% dislocation rate with a posterior approach. But the dislocation rates with lateral approaches in cognitive impairment are quite good, typically under 5%. So for the cognitively impaired patient, I would submit cemented hemiarthroplasty is a treatment of choice, and a lateral approach is preferred. How about surgeon-specific results? There's a lot of talk of this, but unfortunately there's very little data. Are there improved results of total hip arthroplasty for femoral neck fracture when the person performing the surgery performs a lot of total hip replacements, typically an elective arthroplasty surgeon? Would the risk of periprosthetic fracture fall? Would the dislocation rate fall? Would there be a lesser long-term loosening risk? And would be able to minimize the limb length inequality problems? Unfortunately, there's no good data to answer these questions. I think it's reasonable to assume that patients will do better with total hip arthroplasty if managed by an arthroplasty specialist. I think it's also reasonable to assume that if you don't perform a lot of total hip arthroplasties, that hemiarthroplasty might be better for the patient in your hands. How cost effective is it? Is there one procedure that's more cost effective than the other? Well, there was a study presented at the Academy this year. It was an economic decision analysis for displaced femoral neck fractures. And using certain assumptions that maybe not everybody agrees with, it appears that total hip arthroplasty becomes the most cost-effective operation over the age of 55. Under 55, ORIF is the most cost-effective operation. If you look at patients with significant comorbidities, that number falls down to 45. So for femoral neck fractures, cost-effectiveness is 55 the new 70. Should we be replacing everybody over the age of 55, or at least thinking about it? And I think we don't have enough good data to back this up. Time, hopefully, will tell us. So final conclusions, if you look at mortality, it does not appear to be affected by the choice of implants. It doesn't appear to be affected whether it's total hip versus hemiarthroplasty. Arthroplasty is superior to reduction and fixation in most displaced femoral neck fractures in the elderly. I would advocate using cement if you want to minimize the risk of fractures and use a lateral approach to avoid dislocation. At age 60 to 70, I think total hip arthroplasty is perhaps the treatment of choice and certainly appears more cost-effective, but it's reasonable to fix these patients provided that they understand that there's increased failure rate. Hemiarthroplasty should be avoided in this population. At age 70 to 80, I believe total hip arthroplasty is still preferable, but I would consider hemiarthroplasty if one does not feel comfortable doing a total hip, especially through a lateral approach. And over 80 or cognitive impairment, I would recommend hemiarthroplasty. Thank you.
Thanks, Dr. Lorei. Next, we have Dr. Brady.